So we're going to start off, first of all, with Suzanne Barrett, who will be presenting on rates of common mental disorders in Northern Ireland, England, Scotland and Wales, 1991 to 2022, evidence from GHQ-12 survey data. So really topical. Suzanne is a chartered research psychologist working in the Impact Research Centre, Northern Health and Social Care. She has experience in all aspects of clinical trial planning, setup and delivery in mental health, and she recently completed a consultation with QUB and Oxford academics regarding an NIHR-funded RCT. Suzanne is completing analyses comparing historical longitudinal mental health in the UK population from a Northern Ireland perspective using microdata obtained from our favourite organisation, the UK Data Service.
So I'm going to present a talk today on the rates of common mental health disorders in Northern Ireland, England, Scotland and Wales from 1991 to 2022. And we're going to be looking at evidence from BHPS, UKHLS, Understanding Society Survey. So it's widely reported that the Northern Ireland population either directly or indirectly accounts for higher rates of common mental health disorders compared to other UK nations. And that's coming from the Department of Health here in Northern Ireland. NI citizens with serious mental illnesses have reduced life expectancy here in Northern Ireland of between 15 and 20 years due to poor physical health compared to the general population. And the Northern Ireland study of health and stress has shown that we have the highest prevalence of mental illness in the UK post-world economic crisis. We're said to have a morbidity that's 25% higher than the rest of the UK. And in terms of mortality, we have an incidence of around 16 deaths per 100,000 individuals per year related to mental illness here in Northern Ireland. Northern Ireland has obviously been exposed to a very long period of civil conflict and has higher 12-month and lifetime prevalence rates of PTSD compared to other countries affected by conflict. And these comparisons have included South Africa and Israel and Lebanon. So once you're looking at all of those data, it can seem that the case is clear that our statistics, our population statistics are demonstrating this higher prevalence. But when we actually go and look for our statistics on the ground from our different organizations and so forth, they're very, very hard to source. Our microdata has been difficult to get hold of. It's not always lodged in the UK Data Service when we go to do these searches to go back and look at primary analyses and so forth. And this was highlighted in a report by the Office for Statistics Regulations. They reviewed and highlighted significant limitations in Northern Ireland's mental health statistics, and specifically a lack of robust and reliable data, particularly from the community and voluntary sectors. We've had the publication of a new mental health strategy here from the Department of Health in Northern Ireland, and one of the measurable outcomes was better mental health among the wider population, evidenced by a reduction of percentage of the population with a GHQ-12 score of greater than or equal to 4, signifying a possible mental health problem. So this led us to think about all the different sources of GHQ-12 data that may exist for Northern Ireland. And given the wide variety of ways in which we can now conduct searches for these data and have the data service at our the various search mechanisms that are open to us nowadays, we decided we would aim to explore the available GHQ-12 population data from national surveys conducted in the UK to determine if there's evidence supporting the assertion that Northern Ireland has higher rates of mental illness compared to the rest of the UK. And our hypothesis was going into this was that Northern Ireland would demonstrate comparatively poor mental health compared to other UK nations over the time period 1991 to 2021, as measured by the GHQ-12.
Just to say, Suzanne, should the slides be moving on? We're still on the title slide.
Oh, sorry, yes. Sorry.
Perfect.
I'm clicking away. It's not clicking away. Okay, so methods. So in December 2022, January 23, we identified surveys containing GHQ12 through searches of the UK Data Service, government and government agency websites, and the UK's catalogue of mental health measures. We have sourced available microdata from the UK Data Service and sourced aggregate data from government websites where no microdata was available, and this was affecting Northern Ireland only. So our analysis of GHQ12 caseness data were explored cross-sectionally by UK nation and year of data collection and longitudinally within countries using comparative inferential tests of significance, Kruskal-Wallis and chi-squares, with multiple comparisons to detail national in-year differences. We looked at effect sizes to control for sample size variation and improve interpretability of findings. And we looked at characterization of the samples by GHQ12 missingness against census information. And we also conducted an examination of sample depletion and renewal over time. So we were pretty holistic in our approach. We wanted to get to know these data pretty well where they were available to us. So in terms of our methods, once we had done a search we conducted a search on the government websites, and that's table 1 there, and we sourced all of the National Health Survey data that we could find for Northern Ireland, England, Scotland and Wales. And we also looked at the catalogue of mental health measures, and it threw up these 19 studies for which there was GHQ12 information. And out of all of that data, in table 2, we identified that the only one that was really appropriate to our aim was understanding society.
Perfect.
So our results. So we looked at the averages across all years that were available for understanding society, and we looked at it in terms of Northern Ireland, England, Scotland and Wales. And we were able to say quite quickly that the hypothesis was not fully supported in these grand analyses. So the estimates, the grand averages estimates indicated that participants from Northern Ireland seemed to be showing a better mental health overall compared to neighbouring UK countries, England and Wales. And they were showing no significant difference from Scotland. We did quite a detailed breakdown. So we looked at every single year and we mapped these, and a lot of these data should be available now on the wellbeing dashboard, but they're not broken down according to the way in which our health surveys are broken down, and our health surveys tend to break the data down in a case versus no symptoms or case subclinical no symptoms. And what we're seeing here is evidence that Wales certainly had very poor mental health for the first section of this survey, with the BHPS data showing that they had much worse health or sorry GHQ12 caseness right up until about 2001. And it was around about then that Northern Ireland joined that survey. Prior to this, where we were kind of hoping that we would have some data available to us to look at the time period, looking at the Good Friday Agreement and all of those types of things. That unfortunately our data wasn't coming in for Northern Ireland until 2001. So we missed a lot of that critical information in relation. So we unfortunately couldn't relate it to the things that we might have liked to at the outset. However, if we look at the data, we can see that it is showing evidence of being better across that time period in UKHLS. The only blip is in 2013, and we might go back and have a look at this again, and it coincides with the flag protests and a big flare-up of trouble here in Northern Ireland, and we can see in that UKHLS not a huge increase in cases, but a sizable increase in subclinical. There was also it coincides with welfare reform here in Northern Ireland as well, that time period. So there from 2011 to 2013 is around about the time of welfare reform and the flag protests here in Northern Ireland. So that particular phase of the data may be particularly interesting to zoom into with regards to this data set. We also mapped it according to the Likert, and this allowed us to be able to look at the well-being data in the charts available online and be able to determine that our data analysis methods were matching up with that which is being produced by the research centre itself. And obviously we have the earlier data, the BHPS data added on there as well. And again, this Likert data is supporting the view that Northern Ireland has similar, if not better, mental health than the other nations, and Wales is the country that's actually standing out as having the poorest mental health. And this can be contrasted with all of the data that we got from the National Health Surveys. So if we look at the National Health Survey, we can see that Northern Ireland there has an average of 18.23% cases, whereas in the BHPS, oh, sorry, here, have I taken the wrong data? Yes, so there it's 57%, 0.41%, 0%, or zero scores on the GHQ in the national survey, whereas that's looking at 57.41 in BHPS, UKHLS, and meanwhile the England is 61, whereas the BHPS, UKHLS is 54.66. and so forth. So you can see that the data coming from the national surveys is very different from those from the BHPS, UKHLS. And so we wanted to kind of stop and think, well, why would the two surveys be producing very different results? And that's simply saying that we mirrored the analysis again with the Likert data in the, sorry. Oh, yes. So there's the breakdown of the data from the National Health Surveys mapped across the years for which it's available. And as you can see, it's a lot more dotty. We have sporadic data from Northern Ireland from 1997, 2001, 2005, but consistently showing that it has worse mental health. And the other noticeable thing here is that there's no National Health Survey data for Wales present in any of the data sets, that when we went looking for it, it was just those three countries for which the National Health Surveys showed data, GHQ 12 data. So in terms of discussion, the body of evidence, it predominantly uses clinical assessment tools and robust diagnostic procedures to estimate rates of mental ill health and related variables in UK population to support a narrative of greater mental ill health in Northern Ireland, rather than this self-report short form assessment of mental health, GHQ 12, used in the BHPS, UKHLS to measure mental health in individuals from selected UK households. Our internal review of GHQ 12 data from UK found lower rates of persons with no symptoms and higher rates of persons at risk and probable cases in Northern Ireland, basically a less favourable profile compared to findings from BHPS, UKHLS and health survey data from elsewhere in the UK. So why the two difference? Well, we think that study design effects may be impacting and are confounding our conclusions drawn from this mental health data. The BHPS UKHLS survey initiation and or sample replenishment coincided with positive improvements in participants' mental health measures, for example, when we looked at the year-on-year data in country. And so we could see that there are underlying study design effects present within the data set that we're looking at. We saw that renewed household recruitment potentially creates errors of conflation in cross-sectional data, masking mental health issues in the population previously assessed. So we were querying quantification fallacies relating to survey stability and participant household retention and so forth within the data sets, and we've looked at that quite extensively. The data from UK health surveys can also be said to be truly cross-sectional. Repeat assessment and interval to retest may affect GHQ 12 responses cumulatively through social desirability responding, for example, in UKHLS. insensitivity to questions over time, and the sample aging effects that may not be obvious in the short to mid-term that's present in the panel data, that's not present in the National Health Survey data. The panel household survey can also show an age selection bias of sorts. So there's an underrepresentation of 16 to 24-year-olds and an overrepresentation of older age groups, where we're sort of defining the population through household reference people. And this is due to, of course, life course trends affecting stable household establishment, where we're likely to be sampling from. We have done quite an extensive analysis of how comparable our data, BHPS, UKHLS, cross-sectional weighted samples of UK nations are, and how representative they are of the underlying populations. And so for GHQ12 completers, UK nations were similar across waves prior to Northern Ireland joining regarding their age and sex distributions and their average household sizes. Their marital status profiles were less similar. The marital status, particularly in Northern Ireland, has been very different compared, the pattern of marital status different to elsewhere in the UK. And the age and sex distribution data was consistent with data from the underlying census. The underlying census data had persons in Northern Ireland been included in the BHPS. They'd have been younger, they'd be more likely to be single, less likely to be separated, divorced or widowed during that period. And after Northern Ireland joined, the differences in socio-demographic variables between UK nations increased among the GHQ12 completers, becoming more noticeable in wave 9 and wave 11 and wave 1 of UKHLS. So now Northern Ireland had the highest proportion of single persons and the lowest percentage of BAME community of all 4 nations. NI diverged from patterns elsewhere in UK in census 2021 and 22. The UK nation with the largest proportion of persons 16 plus with a long-term illness. In contrast, fewer GHQ12 completers from Northern Ireland had a limiting long-term illness compared to other UK nations in the survey. So that may be an indicator of what's going on underneath there. So any questions? That's me.
Now I would like to introduce our next speaker, who is talking on the mental health support gap among intimate partner violence survivors, findings from a nationally representative survey. It's a very important topic. This is Christina Palantza from Bristol Medical School. And Christina is a second-year PhD student at the University of Bristol who is under the supervision of Jean Veena, working on the effectiveness, accessibility and acceptability of mental health care among survivors of intimate partner violence. She has a background in clinical psychology.
Oh, hello, everyone. It's lovely to meet you. Do you see my slides? Now it must be in presentation mode, isn't it?
Yes, perfect.
Great. So, as we said, the mental health support gap. Thank you very much for having me, by the way. This study is focused on intimate partner violence and mental health support for that. I will be calling it from now on IPV. And we know very well throughout the years that mental health and IPV have a very close relationship in different ways, both that IPV leads to high mental distress, which is often common mental disorders, depression, anxiety, post-traumatic stress disorder, substance use, a lot of different disorders, but also that those experiencing mental health disorders are more vulnerable to IPV, unfortunately, both common mental disorders and more severe disorders. So we would think that IPV survivors have a need for mental health care. And we see, though, again in the literature, in both quantitative and qualitative studies, that they face several barriers to accessing mental health care despite their high need. And there is an interesting concept in the literature useful to investigating such matters, the concept of care gap, which is basically an unmet need, the proportion of individuals in need of a sort of healthcare that do not receive this type of healthcare. There is already some evidence from the APMS, and by the way, I forgot to mention, I'm using APMS data from 2007 and 2014, the Adult Psychiatric Morbidity Survey that was presented earlier in the other sessions. Yes, so there has been a study close to this topic already by Bavsar et al., and it has shown that even though it focused on perpetration of IPV, there was a correlation of perpetration with mental health service use, a lot of that was explained by victimization. And in my understanding, that means that many of the participants that were perpetrators were also victims at the same time. This is quite common actually in IPV and abusive relationships, because often individuals that use violence do it in self-defense, and they're the main victim in the relationship. So we already see from this study that there is a correlation of mental health service use with IPV victimization. And in this study, we're looking at what is the mental health care gap for IPV survivors, and is it larger than the gap among people not exposed to IPV? Because I thought we should have an indication comparative to other populations in need. So yeah, we're using the APMS of 2007 and 2014. We're looking forward to accessing APMS 2023 and 2024 to update the evidence I'm going to present. You were familiar, I guess, with the sampling method. It was presented in detail earlier. And as we said, care gap is the proportion of those in need not receiving this care. So how did we define need? We operationalized it as high psychological distress. In this case, it was measured with a clinical interview schedule revised with a quite high score of 18. This is above the clinical significance level, or meeting criteria for PTSD, or having harmful alcohol use, or being dependent on any drug other than cannabis. And we defined mental health support as any access to healthcare, any form of healthcare targeting mental health, that is talking to a GP, community and day services, and specialized mental health care. We did weighted chi-square tests and weighted logistic regression. More complicated analyses are underway now, but I hope I will present this at another meeting. So our sample size for this study is 1,530. That is 725 from 2007 and 804 from 2014. Very interestingly, from those not exposed to IPV that had a mental health care need at this very high level that we described, were about 5 to 6%, while those exposed to IPV that had this high need were about 25%, which is dramatically larger, I'd say. And in our sample here of the 1,530, more than half are people with lifetime IPV exposure, a little more than half. And their psychological distress scores are a bit higher than those not exposed. And our results, preliminary, we still need to update it with the latest wave of APMS. And also there are a few small decisions to be made still, but it's probably going to be that. So the overall gap of both years combined for everyone is 36.7%. And very, very interestingly, in my opinion, the gap for IPV survivors, either lifetime or recent IPV, is significantly lower. For a lifetime exposure, it's at 32.1%, while for recent exposure, it's 29%. while those not exposed have a gap of almost 42%. And in 2007, there were no significant differences by lifetime or recent IPV exposure. And very much in line with the general APMS analysis, the gap is much higher in 2007 for everyone compared to 2014. So the overall gap in 2007 is 41.7%, while in 2014 it fell to 32.3%. And in 2014, we see that the differences by IPV exposure reach significance, but only for lifetime exposure, where the gap is about 26% compared to 39% of those not exposed. The gap for recent exposure is quite close, still it's at 27%, but that didn't reach significance in the chi-squared test. Before we move on to the different patterns of service use, let's look at some demographic differences. The chi-squared tests showed that the gap is higher among men, those of 16 to 24 years old, Black and mixed ethnicity, those of the highest income quintile, those employed, and those not having children. All these received less care, more gap, that. But when we did a logistic regression with all these variables and IPV exposure, we found that all of that was explained by psychological distress score. So everything, even the differences by IPV exposure, are due to the higher distress scores. So those with higher distress, higher need, also use more services. And that's why we see these differences. There was a significant interaction term of income quintile with care gap, with psychological distress in the care gap. We will investigate this further because it means that it holds only for some income quintiles. And moving on to the differences in patterns of service use, meaning what types of services they use, general, community and day, or specialized. We see that IPV survivors received also more specialized mental health treatment at a significant level. And what is important is that this held also in 2007, while when we included general health care, there were no significant differences. When looking only at specialized care, there were already. So this probably means that IPV survivors started using more general health care in 2014, which is also a general trend. And IPV survivors of lifetime exposure, not recent, concomitantly use all types of services simultaneously. And that was significant. And here we can see their exact breakdown of combinations of services. So unfortunately, the highest proportion doesn't receive any care at 32.5%. And when we move on to actual care, the most common is using all types of services at once. This is only for IPV survivors of lifetime exposure. This is very closely followed by using specialized mental health care and general health care at 18.7%. And using only general health care is 13%. I have 1 minute. I've got this. What I find very interesting is that 28% of all survivors receive only medication, and medication alone without any form of talking therapy is 41% of all the care IPV survivors receive. This is not ideal for a population with complex psychosocial needs, in my opinion. And our conclusion is that Yes, IPV survivors use more services, but this is due to their heightened need. So we would definitely say that they still have a considerable unmet need. 1 in 4 is not little, especially given the proportion that receives medication only. And also, I think I see, but these are still to be confirmed, that there is maybe a persistent need given the lifetime exposure differences and not the recent, and also that maybe they face difficulties in the beginning to navigate the system and receive care. But these are just my opinion at the moment. This is my interpretation of the findings. We're looking forward to the latest wave, and our more complex analyses are coming up. Thank you so much.
And we will move on to our next speaker, which is Ladan from City St George's, University of London. So Ladan is a senior research fellow at City St George's. Her research focuses on childhood adversity, domestic abuse, gender-based violence, and the broader social determinants of mental health, of health general, actually, with a particular emphasis on the impact on health. As social epidemiology, she has published extensively and contributed to policy development, and her interdisciplinary approach bridges public health and social science, promoting trauma-informed approaches to violence and public health challenges.
Hi, everyone. So I'm going to talk about the impact, the health impact of intimate partner violence. So just Christina made it easier for me to talk about this topic. So on a similar, a slightly different outcome, but looking at intimate partner violence. This is a team research project, which I'm presenting on behalf of our team. Just to acknowledging UK PRP as a funder for Vision Consortium, which funded this research project. So intimate partner violence is a very widespread global public health issue. It's not specific to any country, but in England, data from Crime Survey for England and Wales indicated that in 2022, 1 in 5 adults aged over 16, they experience IPV at least once in their lifetime. IPV could take many different forms, including physical, emotional, psychological violence, and economic, sexual, and also coercive control or controlling behaviors. IPV is important because it has impact on all aspects of victims' life, particularly women being studied in research, and their health impact being studied also. For example, the impact on depression has been indicated, and also on health behaviors. They are more likely to take on risky behaviors, and also on their sexual and reproductive health. There has been studies indicating that one. And 42% of the women victim of intimate partner violence, they experience at least once in their life the injuries related to violence. And among those who've been killed by the women who've been killed, femicide rates in the world and also in the UK, intimate partner violence or ex-partner are among the most identified perpetrators. So we know these things about from the previous research, but what we are trying to address here are some of the methodological issues we're trying to address, and also, so I'm going to go through them. For example, most of the research in the impact of IPV on health use predominantly a woman's only sample or neutral sample, so not distinguishing between women and men, and less information is available among men. Like men are also likely to be the victim of violence, and some research, I haven't seen that in the UK, but in other parts of the world, there are some population-based survey that's showing men are roughly equally likely to report IPV. But the question is it the impact of IPV is equally impacting men or women? So we are trying to address that one in this research as well. Most of the samples are coming from clinical sample or coming from specialist services for victim of violence, which means the findings are less suitable to be generalized to general public general populations. Also, most of the research, not just in the UK, also, and actually globally, they are more likely to be focused on physical and sexual type of IPV, and less information is available about non-physical, non-sexual, or as we describe it, non-visible type of violence, including emotional, psychological, economic, and coercive control, which is important because they are very prevalent. So it's important to capture the impacts as well. In terms of the outcome, most of the research published by some of the people in this session as well, including Sally and the colleagues, they also been focused on mental health outcome of IPV. We're trying to focus on a different type of health outcome, specifically a specific physical health outcome. And also some of the research in this area been focused, which capture the physical health. They've been focused on general health or quality of life or acute impact, like injuries, but not on a specific chronic health conditions. And also research has been criticized for not measuring sufficiently adjust for important covariates, including socioeconomic status and childhood abuse, which are known contributor to physical health. To address these gaps, we aim to explore the association between different type of IPV, not only physical and sexual, to also include psychological violence and economic abuse. And we were also interested to look at the number of IPV people experience. So not just treating the IPV as separate incidents, but also to look at when they are happening at the same time for the same victims. And we were also interested to look at the gender differences in these associations. So I'm not going to go through the APMS. You already heard about APMS in the morning session and also in previous sessions, but just briefly, we are using 2014 because the new one is weren't released at the time we were analyzing data set, and it's a random sample, 57% response rate, and less than 8,000 participants were included. The type of specific health conditions we included in this study, as you see, are quite wide range, and I would say kind of first of its kind to look at such a broad range of the physical health conditions, from cancer to a skin problem, hearing problem, insight problem, cardiovascular disease, or neuropsychological conditions, and so on. We look at both lifetime, if they have ever in their lifetime experienced IPV, and the recent one during within the 12 months period to data collection. And also we look at the numbers of IPV, 1, 2, 3 or more type of IPV if they experience. Yeah, that was what we did. So the first finding we are looking at, sorry that you cannot see the numbers as big as if it was for the full screen, but I'm going to read through. So for the prevalence of IPV, we found that if the blue bar are for women across the figures, and the woman, this is only for experiencing any type of lifetime IPV. So I'm not breaking down by type of IPV here because we don't have time for that one. But for lifetime IPV, women were more likely to experience than men, 27 compared to 16. And when we look at the 12 months, the same pattern, almost twice more likely to experience IPV in the past 12 months. When looking at the number of IPV experience, we see that for the 1 is very similar, like 11 compared to 10, but for the higher number of IPV, women were way more likely to report it. So 10 compared to 3 and 6 compared to 1. This is what we see here. I just created this one just to show you for those who did report any type of IPV in their lifetime, women were 60% of women were reporting at least 2 IPV type. This is compared to 35 for men, almost, not exactly, but almost twice more likely to experience multiple type of IPV. What we found in terms of association between, so Sally, you need to shut out. I don't see you on the screen, so you need to tell me when that's 1 minute.
Oh yeah, it's moving on, but just to say you've got sort of 3 more minutes, then we've got
Okay.
5 minutes
It
to
should be
question.
enough.
You can go over a bit, but
it should be enough. Okay, so for women, when we look at the association between lifetime and 12 months IPV with those 19 specific health conditions, I just show you for women, 12 and 11 different physical health conditions, they showed significant association after adjusting for wide range of socioeconomic status plus age plus ethnicity and experience of physical and sexual violence during childhood. But for men, when we repeated the analysis for men, only 4 conditions for lifetime IPV and only 1 condition for 12 months IPV remains significant after adjusting. So you see here, if you could see here, I'm going to read through. So this is exactly the same finding I just reported for. This is only for women sample. And this is the kind of disease that shows significant association after adjusting for age, ethnicity. If they could keep home warm in winter as an indicator for poverty, and if they had any debt, and for the area deprivation level. This is not adjusted for childhood adversities, physical sexual violence. But as you see, those 12 are like migraine, sight problem, hearing problem, heart attack, high blood pressure. Sorry, high blood pressure is not significant. And asthma, so liver problem. Most of them, they were skeletal problems and digestive system and immune system disease-related problems that were significant. And I'm going to show you men results. I just explained. Only 4 of them were significant. They were migraine and bowel colon problem and musculoskeletal disease and also infectious disease. There were only 4 of them that were remained significant after adjusting for socioeconomic factors. When we look at the number of IPV and health outcome, we saw a dose response association, so which means as the number of IPV experience increase, so did the number of health condition which had significant association with IPV. But we haven't seen the similar pattern for men. So for men, higher number of IPV, we didn't see a dose response, a consistent dose response association between IPV and the number of health conditions with significant association. Adjusting for child sexual abuse did not much make a big difference for women, but for men, most of those 4 significant association did not remain significant after adjusting for childhood abuse. So, in conclusion, IPV should be considered as a gender issue as it has a more significant association for women than men. But there are so many things that could contribute to these gender differences, including that women are more likely to experience more type of violence, more severe type of violence, more impactful type of violence. They are more likely to live with poverty. They are more likely to trap in abusive relationship, and they have prolonged extensive exposure to IPV which make it even more difficult for them to seek help, or for the sake of their children, sometimes they feel like they have to stay in the relationship, and that would have impact on their health. And also, as you heard from the other presenters, IPV has an impact on mental health, and that could lead to impact on physical health. And for all of these, women are higher risk. Healthcare system should recognize IPV as a priority issue, and making sure that the support is available, and the NHS and the people working in NHS health providers to be well enough trained to identify the victims and to refer them to the system that could help them. If you are interested in the paper, this is a QR code, and this is the link to the paper. And thank you.
We can move on to our next and final speaker of today. So this is Veena Muraleetharan. But Veena will be speaking on understanding associations between sexual identity change and the mental health of lesbian, gay, bisexual adults in the United Kingdom. So Veena is a research assistant at the London School of Hygiene and Tropical Medicine, where she focuses on relationships and sexual health education in secondary schools in the UK. Recently completed her MPhil in Population Health Sciences at University of Cambridge, where she completed the research presented here. She has experience working in health policy and civil rights in the US and a background in medical anthropology. All yours.
Thank you, Sally. Hi, everyone. My name is Veena Muraleetharan, and I'll be presenting today on research that was conducted while I was a master's student at the University of Cambridge, and then written up while I was a researcher at LSHTM. And I would like to thank my supervisor, Dr. Katie Saunders, for all her support with this research. So yeah, as this title indicates, this research is looking at the associations between sexual identity change and mental health outcomes in sexual minority populations in the UK. So to start off with, I want to speak a little bit about why we need this research. So there's a large body of evidence that shows an increased risk of mental health conditions among sexual minority populations. And I really want to emphasize here the structural factors that play into this. I'll speak more about that in a second, but it's really important to recognize how discrimination at a societal level is a large driver of these mental health disparities that we're seeing. We also know that there are differential mental health outcomes within sexual minority populations. So some of the largest disparities are seen for bisexual women. But one thing that's important to note is much of the evidence to date does take sexual identity as a stable category. So it kind of assumes that people are going to report the same thing across their life course. However, there's growing evidence that there can be changes in sexual identity across the life course. So it's really important to see how that shapes mental health outcomes, given what we already know about the disparities in LGBT communities to begin with. And so I used Understanding Society's panel design allows for us to look at this measure of sexual identity change because we have data on the same people over time. So I want to start by grounding this in some different theoretical background. The first is Myers minority stress theory. So this helps to explain the increased risk of mental health issues experienced by LGBTQ+ people. So Myers talks about how societal discrimination creates distal factors like school-based victimization, violence, harassment, and employment discrimination. These impact the mental health of LGBTQ+ people, but also lead to expectations of negative attitudes that can lead to more proximal factors, things like concealment and internalized homophobia that also harms the mental health of sexual minority and gender minority populations. So when it comes to those whose reporting of sexual identity shifts across their lifetime, this can have maybe conflicting impacts on mental health. So for those who move towards straight identities, they may experience have fewer experiences of discrimination if they're perceived and identify as straight. But if this represents concealment, that could also harm their mental health. For those moving towards LGBT identities, they might experience more discrimination. But as Myers points out, incorporation of LGBT identity into a larger sense of self can be really helpful for improving mental health outcomes as well. In both directions, some have theorized about how loss of social support from previous identities might harm mental health as well. So given this, it's really important to look at what this, how this plays out quantitatively with the data available in Understanding Society. I also want to briefly talk about what I mean when I say sexual identity. So researchers have theorized that sexuality composes a few different components. One is attraction, one is behavior, and one is sexual identity, which is one's own sense of self. The definition that you choose to use does shape the estimated size of sexual minority populations. This study chooses to focus on sexual identity, one, because it's the only one of these components that Understanding Society routinely collects data on. And we also wanted to respond to social scientists who point out how a focus on behavior overlooks the social and cultural dimensions of identity and also undermines sexual minorities people's self-determination of their identity. I also want to really emphasize that in no way is the study indicating that sexuality is choice. Instead, we're grounding this in the theory of sexual fluidity, which Diamond, a leading researcher in this field, defines as a capacity for situation-dependent flexibility in sexual responsiveness. This is another component of sexuality that works alongside sexual orientation to shape desire and behavior, and it's also outside of an individual's control. It may or may not manifest in identity changes, so the data we have can't fully capture the phenomenon of sexual fluidity, but what it can tell us is how shifts in sexual identity, shaped partially by sexual fluidity, but also by experiences of minority stress and changes in understanding of one's own self, how that associates with different mental health outcomes. So as I pointed out earlier, there are a few studies in this area. One systematic review on sexual identity shift found that those who did look at mental health outcomes found that those with non-heterosexual identities and shifts towards non-heterosexual sexuality had higher likelihood of mental health conditions. Another study, Irwin et al., which was conducted in 2021 using Understanding Society data, found that changing sexual identity was associated with worse health outcomes in terms of life satisfaction, mental health, and physical health. So this study builds on Irwin et al. By incorporating additional sexual identity data that's collected more frequently from young adults, so those ages 16 to 21 in Understanding Society, and including new data that was captured in Wave 13 with a new question looking at specific mental health conditions. And so we're trying to understand the associations between sexual identity change observed from Wave 1 to Wave 13 of Understanding Society, and their associations with psychological well-being and self-reported mental health diagnoses in Wave 13. So the sample for this study were participants in Wave 13 of Understanding Society that were age 16 or older at the time, had complete sociodemographic characteristics for the selected covariates, which I'll go through in a second, from either Wave 13 or carried forward from a previous wave, and at least one sexual identity observation from a current or previous wave. They also had complete data for GHQ-12 or self-reported mental health conditions. So this led to a sample of about 25,000 participants for the study. So I want to talk briefly about how we define sexual identity change. So it's important to note that Understanding Society only collects this information from all adult participants in waves 3 and 9. So we weren't able to necessarily look at what the immediate outcome was after someone changed reporting of sexual identity. And so instead we look sort of across the waves to see their entirety of sexual identity responses and categorize them in this way described in the table below. And so this measure accounts for direction of change. And I do want to note that we do include those with only one observation of sexual identity change in the no change categories. This is because there was the immigrant and ethnic minority boost sample that was added in Wave 6, and we didn't want to systematically exclude those individuals from the study. We did run a sensitivity analysis, not including those with only one observation, and found the results were mostly similar. We also include prefer not to say as a separate category for changes in and out of, and this is is because of the role that concealment might play in minority stress as well. So the outcome measures that we looked at were first psychological distress as measured by GHQ-12, and we used the Likert scoring for that, which gives a range from 0 to 36, with higher scores indicating more distress. We also use this new question from Wave 13, which asks about self-reported diagnoses of mental health conditions. And we did a preliminary analysis and chose conditions with greater than 2% national prevalence and more than 500 participants reporting to look at individually. So those are the ones in dark green here. And then we also did an analysis of any mental health condition, excluding ADD, postnatal depression, and dementia, given the sex-based or genetic-based determination of these conditions. So this first line gives the covariates that we did control for in the model, and this was based on the literature showing that these could both impact the likelihood of changing sexual identity as well as mental health. We chose not to control for income or employment status, and this was responding to some researchers who pointed out how these factors could lie on the causal pathway to worse mental health for LGBT individuals. So Myers theorized how employment discrimination might be a factor in worsening the mental health of LGBT individuals, and so we didn't want to control for these and underestimate the impact that minority stress might have on the participants in our study. I also want to point out why the study can't look at the experiences of transgender communities despite despite these individuals having some of the worst mental health outcomes within the LGBTQ community. And that's because the gender response options in Understanding Society only include male and female, and it's only collected from one household member rather than being individually reported. So it's quite difficult to identify transgender participants within the study. We had less than 10 participants whose gender response changed over time, and so we did have to exclude them from the main analysis, but ran a sensitivity analysis to see if that had any impact and found the results were mostly the same. So in terms of our statistical analysis for both GHQ-12 and odds of reporting mental health conditions, we did survey-weighted regressions. This gave us an estimate for both change in GHQ-12 and adjusted odds ratios associated with sexual identity change groups. We used a Rouse-Scott working likelihood ratio test to get an overall p-value for sexual identity change. And then given the interrelatedness of our analyses, we used a Benjamini-Hochberg correction to account for multiple testing. We did explore gender effect modification, but found with a stratified analysis that confidence intervals were mostly overlapping, so proceeded with a non-stratified adjusted analysis for our main analysis. So briefly going through some of the descriptive statistics we found. So the smallest group for any of our analyses was 37 participants, which was in the LGBT to prefer not to say group. But we did find that approximately 10% of the population reported an identity other than straight at some point in the study period. And we did see differences in the groups in terms of immigration status, gender identity, and race and ethnicity. However, this was accounted for with adjustment in our model. So these were the main results from the study. And so starting at the top here with the Rouse-Scott p-value, we see for all outcomes, except for PTSD, sexual identity change was a significant predictor of the outcome. Also looking across the models, we see for those who consistently report a bisexual identity, those who change from straight to LGB, and those who change from prefer not to say to LGB, all had consistent disparities across the models where sexual identity change was a significant predictor. Looking at GHQ-12, which is our measure of psychological distress, we also see that those who change from LGB to straight had higher levels of distress than their consistently straight identifying peers. These individuals also had higher odds for reporting any mental health condition and depression specifically. And then looking at groups that currently identify as LGB, all of these groups, with the exception of those who consistently report other as their identity, they had higher odds of any mental health condition and depression specifically as well. So how does this fit in with the existing literature? So first of all, we see how it aligns with existing literature showing worse mental health outcomes for LGBT groups, and in particular bisexual individuals. We also have some new insights. So we see how those who change from straight or prefer not to say to LGBT at some point in the study period also showed consistent disparities across the outcomes that we looked at. We also capture a group that maybe was not previously identified in research that took sexual identity as a stable category, which are those who change from LGBT to straight. And this group had both higher levels of psychological distress and higher odds of reporting any mental health condition and depression specifically. So these findings point to the role of community support disruption as a potential minority stressor for those who changed reporting of identity, as well as things like concealment and other proximal stressors that could still impact people who shift from LGBT to straight at some point. So what does this mean for policy and practice? First of all, it's really important to account for nuances within sexual identity when responding to the mental health needs of LGBT populations. We already know that other factors like identity within LGBT communities or race and ethnicity can shape mental health outcomes, and this is another element that should be thought about when clinicians and practitioners are responding to minority stress. We also know that therapy models that center minority stress have been shown to be effective, and these could be expanded to respond to the unique stressors that those who change sexual identity experience. These could also take into account some of the disparities we saw for particular conditions as well. Finally, I think there's a really clear indication of the importance of collecting sexual identity data more frequently, given that, again, it's not a stable category for all individuals, and it's important to think about how that change can shape outcomes as well. Directions for future research include exploring why participants answer prefer not to say or other. We chose to include these participants in our study, again, given the role of concealment and the importance of including those with identities beyond lesbian, gay, or bisexual. But this could be an interesting direction for qualitative research to explore as well. I think it's really important that we have better data collection on gender with trans-inclusive response options and allowing individuals to do this in a self-completion setting. Again, given the largest disparities that we see for trans individuals within the LGBTQ community. We could also explore data linkage with medical records to see how underreporting might impact the results we got for specific mental health conditions. And again, I think it's really important to explore nuances like differences by race and ethnicity. We already know that people of color within the LGBTQ community have worse mental health outcomes than their white peers. And we did try to look at this within the study, but we didn't have enough participants to have adequate sample sizes to do a stratified analysis, but this could be explored through qualitative research to understand the experiences of sexually fluid people of color as well.
Thank you, Veena. That was such a brilliant illustration of how longitudinal data can really provide us with a very sort of novel way of looking at how it can provide us with an insight into how change across the life course. And I thought that was brilliantly pulled out. I think we're moving now towards the closing stages, and we've got others coming back into the room now. Vanessa, I'll hand over to you.
Yeah, I won't keep you very long. I know it's been an interesting but very long day on Zoom. So yeah, thanks to everyone. I think it's really showcased such the wide range of health study data that are available from Data Service for secondary analysis. I just wanted to come back to the issue of the important session from Department of Health and ONS about the future of population health surveys. So I'm hoping that most people who were here listened in, but there was obviously a very concerned audience regarding the health survey for England finishing after the 2025-26 issue, and then something replacing it, but we don't know what it will be yet, but the decision is going to be made in a very short time frame. So in terms of follow-up from that session, and I'm very conscious of the short time frame and the fact that it's the summer. So UKGS, we can send some target data users to feed into the process more, and we can publish a blog about the key messages from the talk and publicise that with the questions and answers, which were really good. And we'll circulate that widely, and we can continue to liaise with Tim and Paul to get updates on some of the unanswered questions and how I think you as users need to send your thoughts to Tim individually, as he stressed, I think via the future health surveys email. I think we can add that to the chat or send it to you separately as follow-up. I think it's really important that we do this as the group of population health survey users, because I am concerned that the people who he has heard from aren't particularly representative. There weren't enough people feeding in. They didn't realise how important it was. So, and also if you have any further ideas for collecting user needs, please do get in touch with me or with Future Health folks directly. So yeah, it was just to say that, really, to urge, as a community of data users, you really want to be influencing and putting your voice across, and whether or not it will make much difference, we don't know, but they are interested in hearing views. So I'd really urge everyone to do that. And it's likely that it's going to affect more than the Health Survey for England, this, by the sounds of it. So anyway, on a more positive note, I have a few thank yous as always. So thank you to our keynote speaker. I'm not sure if she's still here, Lola. And thank you to all our other speakers throughout the day. Thank you to all the chairs during the day who always do this voluntarily. We love you for doing that. Thank you to our conference partners at UCL and NatSen, and special thank you to the UKGS team behind the scenes who worked really hard to make this conference a success, whether it's in person or online. So it's Jill Meadows, Emma Green and Ali Bloom. And finally, thank you to all of you for your participation and your searching questions and enthusiasm throughout the day.